Hi everyone, thanks for joining. We're going to get started now. Just a reminder, we have 30 minutes, one question, one follow-up. Today we have Dr. Williams and Dr. Yaffe here today, so I'll turn it over to them for some brief remarks.
Yes, good afternoon. Monday. That means we look back at what happened over the weekend, where we are, and what we're expecting and looking at as the week proceeds in that. And so we have some numbers, and then I'll have some comments afterwards. So first I'm going to hand things over to Dr. Yaffe to give some data of what happened over the weekend and where we are today in the different metrics that we're looking at in that. So it's 1st of March, we're into another month, and there's a lot of things happening, but I'll comment on that later. So over to Dr. Yaffe.
Thank you, Dr. Williams. Good afternoon, everyone. Since our last update on Thursday, Ontario is reporting an additional 4,528 cases of COVID-19. That's 1,258 on Friday, 1,185 on Saturday, 1,062 on Sunday, and today 1,023 cases. The new cases in today's update include 280 in Toronto and 182 in Peel Region. Our 7-day average for daily cases is currently 1,099, which is slightly higher than the same period last week when the average was 1,045 cases. We're also reporting an additional 70 deaths since our last update on Thursday, which includes 6 today. Our 7-day average is 16 deaths per day, which is down from 24 for the same time period last week. Today, we have 659 people in hospital with COVID-19, up from 646 last week. The number of people in the intensive care unit is 280. That's a slight drop from yesterday, but remains unchanged from last Monday. We offer our condolences to the friends and family who have lost loved ones, and we offer our thoughts to those who are in hospital and recovering from this disease. With respect to testing, today we're reporting just over 35,000 tests completed, with a percent positivity of 3.1%. The average percent positivity over the last 7 days is 2.6%, which is slightly lower than 2.7% for the same time period last week. Overall, when we look back at the month of February, Ontario averaged 1,164 cases daily, 28 deaths per day, and almost 49,000 daily lab tests with an average percent positivity of 2.9%. Today, we're reporting a total of 565 confirmed variants of concern in Ontario. Of those, 535 are the B.1.1.7 variant, which was originally identified in the United Kingdom. 27 are the B.1.351 variant, originally identified in South Africa, and 3 of the P1 variant, originally identified in Brazil. In addition to the officially confirmed cases of the variants of concern, we are now also publicly reporting on those COVID-19 samples that screen positive for the N501 mutation. As of February 25th, 19,232 samples have been screened for the 501Y mutation, with a positivity rate of 11.9%, or 2,291 cases. When we look at the most recent weekly data for the week of February 19th to the 25th, 5,953 samples were screened for the mutation, and of those, 18.9%, or 1,125, came back positive. Just to note, if they're positive for this mutation, it means they could be any of the 3 variants of concern that we're dealing with, but it does mean it's one of the variants of concern. With that, I'll turn it over to Dr. Williams for further remarks.
So effective today, as of midnight last night, 9 public health units moved to different levels of our provincial color-coded framework as we implement back in again and have various levels of restrictions depending on what they're experiencing in their respective jurisdictions. Still, Toronto, Peel Region, and North Bay Parry Sound District Health Unit area remain in the stay-at-home orders, which were moved under the ROA and effective until March the 8th on that. And then this week we're reviewing that again, and then as they enter the framework to determine how and what would be recommended to Cabinet as the week progresses. And that would be effective on midnight of the 7th or 12:01 on the 8th. The final decisions there depends on the indicators, consultation with the local medical officer of health, and see if there's any outstanding issues that have to be brought into consideration at that time. As well, we have 2 health units that, besides a number of them moving down in the framework to different lower colors, some remain the same. We also have moved Thunder Bay District into the gray lockdown zone. This has been an escalating situation over a number of weeks as they've dealt with multiple sites of outbreaks and community spread within their jurisdiction. And so we've been in constant consultation with the medical officer of health there, Dr. DeMille, as well as looking at many calls between myself and our teams and others of giving assistance to them as they deal with this surge of cases in their respective jurisdiction, more they experience in the first wave than and also up to now in the second wave. So this has been their biggest or largest outbreak community-wide and institutionally that they've experienced. And so, excuse me, we would want to give them all the assistance we can to help them to bring this back under control. As well, last week we did move Simcoe Muskoka into the so-called gray lockdown zone, under the concept of the emergency brake type idea. And that was where we saw a sudden surge in the VOCs in the jurisdiction there over the 2 to 3 days, where it went up almost like 60 to 70 new cases a day. And we were trying to ascertain where they were and what was happening both in the Simcoe area, but also a surge of new cases in the Muskoka area as well. And part of this methodology here is that now we're into this era of the VOCs, the variants of concern, knowing that their transmission can occur much quicker than the previous COVID-19 strains. It behooves us to move quickly to try and bring it under control, much like we had to do in North Bay, and try and ascertain if we can keep it contained to a local outbreak situation or not, because unfortunately it does move quickly, and unfortunately it does have morbidity and mortality attached to it, and we would like to maintain and keep that down as much as possible. So we know this is upsetting to some of the local individuals and people, but it's the same as when there is other warnings like weather stuff and that. If you go ahead of time and move up, you can prevent people from getting injured and hurt and that. At the same time, we want to be cautious and careful, and we are assessing these situations both in Thunder Bay and Simcoe Muskoka on a daily basis, as well as reviewing with them with their local teams to see what's going on and how we can best assess and ascertain what's going on and what extra help and support we can give to each of these jurisdictions to in their assessment, in the response, and other adjunct processes that they may want to take to ensure the ongoing health and safety of the residents in their respective jurisdictions. So it's important to do that. The province is also looking at other ways we can give support on the broader level, as there's some other health units have some areas of concerns they're trying to deal with as they see with the variants of concern a sudden surge that because of the time to get those tests in line to assess those, and then what can they do to put in processes to ascertain, is it a local outbreak, is it a community-wide spread, and what can you do to control that? Because as we went through with our modelers last week with Dr. Brown, we're in this tenuous period where our numbers are down. We're still hovering around that 1,000 every day. We may even dip below 1,000 and go above 1,000. But as we do that, as you see the percents of it, we had some numbers today. I've had some updates that we're over 20% with a 7-day rolling average coming up in the more recent dates there. So we see that the percent is rising. even as the number of positive tests are going down, the question is, can we keep them there, as they were concerned with the modelers that they'll start to cross over. And every time you're in that little level of each health unit is a start on that exponential rapid rise. And we have to move very assertively ahead of time to see, can we contain that? Can we constrain that and keep that rise flattened to some extent if we could, but even not as steeply as we've seen it happen in other jurisdictions. So this is a real challenge for us, and we're hoping to undertake to do this even as we are making inroads with our vaccination programs to, first of all, get our high-risk areas, our long-term care residents, our retirement home residents, and the staff in each of those situations, in those high-risk congregate settings, vaccinated as soon as possible. And already we're seeing very good results from that, with the number of outbreaks going down, the number of cases positive in residents and staff going down, as well as the rate of deaths going down in these cases, because death is a very late responder to that. So we're very encouraged by that, and seeing some days with no new outbreaks in long-term care homes reported, which we haven't seen till way back in August. So these are encouraging signs as we roll out our vaccination program, and with all the things that are happening internationally and with new products coming online, it means we're moving into a very forward-moving step at this time to move and try and bring even more and more control under this, as we hope to fend off and keep these variants of concerns under control and not experience the sudden big surges that some of the other countries had seen in Europe and other areas. Unfortunately, they had experienced those. We do not want to do that. We want to continue to do our personal protection, and it doesn't really matter which area in the framework you're in. The personal steps are still the same. We've emphasized that before. It's very critical, especially these variants concern that can be transmitted much more easily between person to person, that you are very vigilant, even if you are partaking in some of the newer things that are open again for you in your various color zones where you are, that you take all those steps there to protect yourself, your family, and your loved ones from obtaining the virus, especially the variants of concern in that. And as a result, if you keep those ones down, we keep that down, that means that your health unit area can stay down in the color zone. But we are making it so we can go up very quickly, and we need to respond quickly, because we have been appraised by our scientific table that if you do not move quickly to put some controls in place, it'll probably be too late by the time you get to take action. So we're going to have to be more proactive in that step on a precautionary basis, so we can keep a handle on that. So again, be careful, be consistent, wait for your vaccine. It's coming. We want everybody vaccinated, not just some. We want everybody done in a timely pattern. We have our ones with high risk. We're moving our way through that. We're heading well over 700,000 vaccinations have been given already, and we hope with more supplies arriving, I know the General would really like to pick up on that pace, and we would like to too, across the whole province. All our health units are ready to roll as soon as we can, but it has to be done orderly. We have to document who got it, when they got it, because if you have to get some second dose, you need to know when and how to get that, as well as you need that documentation to show that you have received the vaccine when you had it. Plus, we want to make sure we can track if anyone has any side effects at all, even though we've had very small amount, but everyone is important to be noted, because we want to make sure we continue to monitor that our program is safe, and we want to keep documenting that. So the program's going ahead as quickly as we can, but we want it done consistently, carefully, with safety in line, as well as documentation, as we're going to get ready to do that. And we want to try and get everybody vaccinated as soon as we can. And we like those vaccines to come in even quicker if we could. So with that, I'm going to hand things over to the media for questions.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
Anthony Fury, Post Media. Please go ahead.
Hi there, Dr. Williams. Peel Region Health has apologized for telling parents they need to quarantine children who may have been exposed to the virus in isolation from all family members. However, there are still multiple public health units that offer similarly worded guidance for when kids are dismissed from school. And all those public health units, they say they are simply following provincial guidelines. So can you clarify for all those frustrated and, outraged parents that we're hearing from, what the province-wide position actually is on this matter?
Okay, and I'm going to hand that over to Dr. Yaffe to answer that one. as he does a lot of the case contact management issues.
Thank you very much. I mean, we know that if somebody may have COVID-19 or they've been a close contact of somebody with COVID-19, we would like them to be isolated for up to 14 days, which is the maximum incubation period, because they may develop the infection and become infectious to others. However, we obviously understand that you can't leave a child alone in a room for that period of time. And so you have to use basically common sense and say, you know, if your child had measles or some other infectious disease, how would you handle the situation? And you would make sure that the child, obviously, you're caring for the child, but you use proper infection prevention and control. If possible, you wear a mask, you wash your hands well, you make sure the child is obviously not exposing others in the family as much as possible. Hopefully only one or two people need to care for the child during that period. But you do not leave the child alone in a room for 14 days. So I think perhaps it was just the choice of wording was probably not optimal. But it is important to try to minimize the spread of infection. And there are instructions for that on the Public Health Agency of Canada website, Public Health Ontario, and so on. And if in doubt, you consult your health unit or your health practitioner in terms of how you would deal with it. But use common sense, try to prevent transmission of infection, but take care of the child.
Follow-up?
Okay, but you've said many times that the contact tracing reveals that there has hardly been any in-class transmission at all throughout the province, and that is one reason why schools are safe. So why then does a child who was simply in the same room as another child who later tested positive, and therefore based on what you've been saying is extremely unlikely to later test positive for the virus, why does that child even need to be kept indoors for 14 days straight and separated from pretty much all other family members except for a caregiver?
Well, I mean, it isn't common to have transmission in schools, but unfortunately, as you've heard, we are now dealing with variants of concern, and in some instances in the school setting, and they are at least 40 to 50% more transmissible than the usual normal variant of COVID-19. So we need to be extra cautious. This can spread very quickly, and so we want to be extra careful and make sure that we minimize spread.
Next question.
From Mike Crawley, CBC News. Please go ahead.
Yes, hi. I'm wondering, I know this Dr. Williams or Dr. Yaffe could answer this, but there's a lot of confusion out in the community about the fact that some public health units are vaccinating people in the 80-plus age groups, and some are not. And you know, the excuse we're getting from Toronto is that they have a larger population that they have to vaccinate among healthcare workers. But could you explain whether this is appropriate or not? I'm sorry. Could you explain whether that's a problem or why this is happening?
So, yeah, it's a good question. And I think what we're trying to do, as we always do with our vaccination programs here in Ontario, because our public health units have been undertaking population vaccination programs for many years, and the flu campaign is just one example. What we understand is that the demand and the need varies from area to area, and we like our health units to respond to that, still keeping to the priority list they're supposed to deal with. The fact that there might be a difference between one health unit to another and one can proceed on to the next group on their priority list, I think is only but reasonable in that situation there, because if you have to wait for everybody to finish one level, then there's going to be vaccines sitting in fridges while you wait for everybody to get caught up, because the demographics are not equal everywhere. And so what you want to do is to move them through as judiciously as they can, because the idea is we want as many people vaccinated as soon as possible in the context of the priority list in the proper way in every health unit. So while people would like to be doing some trading off and comparing, you need to talk to your health unit, because they're following the priority list, but they're doing it in a way that they're not holding up while they wait for everybody else to get up to the same speed. In the end, the task force still looks at it and says, have you covered all this on this level, in the first level, before you go to the second and the third and so forth down the line? So there is a monitoring of the overall response, but we don't want health units sitting there saying, well, we got fridges full of vaccine and we're just waiting for everybody to get ready for us. We don't want that. The task force doesn't want that, and the public, I don't think, would want that either. So there will be variation because our health units are not demographically all the same.
Follow-up?
On another topic, we're wondering when we're going to find out who is designated as essential workers to be vaccinated as priority groups in phase 2. Has the recommendations been given to cabinet? And people are wondering, teachers, are they going to be part of this? Grocery store workers, who are the kind of people that will be eligible to be vaccinated as part of the essential worker category?
So, as you know, the committee and the task force is working through that to get that identified. We have recommendations from our central, federal, provincial, territorial one to say, as you're going through, you need to be looking at the ages. And because the high risk there is the first, and we're trying to do that, is the over 80s, the over 70s and 60s and so forth, because those are the main one that ends up being in with mortality, unfortunately, but also with morbidity, populating our ICUs and with our healthcare system. So we have to meet that list, as well as some other key ones that were identified in level 1 and 2. So we're trying to say we'd like to get that list done. We can probably, sometimes we get enough vaccine, move through those ones fairly quickly. And we want to make sure we are sensitive to what those essential ones are. At the same time, everyone has some perspective of why there's a criticality that they would be vaccinated right away. And we know those are important features. What is the good thing, I think, is that we have a real strong desire of everybody to get vaccinated, and I would really applaud that. We would like to get that done as soon as possible, and that the differential between level 2 of these age groups and essential would be a very shortened time frame. The volume being, as if we can get it up, we'll be moving through those fairly quickly, and so it becomes even less of an issue, maybe a delay of a week or so. But the main issue right now is we want that vaccine volume up and to move through it as quickly as we can. So we haven't made the recommendations definitively yet on the essential list, and we're going to be working through that on a lifetime basis on our supply levels as well.
Next question.
From Randy Rapp at CHCH TV. Please go ahead.
Yeah, hi, doctors. I'm wondering, with people being vaccinated now, and a lot of the vaccinations, some of the vaccinations completed, how long till people that are vaccinated can get out and about? When can they roam freely about the province from one area to another and start to live a more normal life?
Well, this is a very important question. And as we start to see the evidence that we're going to get large parts of our population vaccinated, at least with one dose, and can we get the 2 doses in different times and different eras to make sure we have enough coverage. And right now we've got pretty well all our long-term care facilities done. Nearly all our retirement homes are getting there. We still have some staffing to get done in those situations there. And we want to complete that. We have some other ones as well. When you start getting out to the general population, as we're now starting to encroach on that with our over 80s and moving to that category there, we know there are going to be more and more individuals that'll become that. So we're trying to address that live time to say, if you have enough vaccine and documentation and coverage in that, what does that mean? What does it mean as far as ongoing testing in some centers? What does it mean as far as movement in around there, movement within the framework? Can you do activity A, B, or C in that matter there? And this is a good challenge to have because we'd like to address that on a proactive basis. It's not right in front of us yet, but we're having live discussions at this time in a way that could be laid out in an orderly fashion and in a way that makes sense to the public as well as to the healthcare providers and individuals in there, because what we want to do is to try and decrease the spread from person to person as much as possible. Right now, we know that some of the vaccines have a great impact on reducing morbidity and mortality, but we're not sure yet if it decreases totally transmission. And so we're probably going to do some parallel work on post-vaccination to do some testing on people and seeing from our own data is the positivity on those tests dropping down considerably. And of course, we're doing that with our ongoing screening in some centers like our retirement homes and long-term care facilities. So we're going to keep an eye on that and be informed by that ongoing population research to make some decisions. So that's ahead of us, and I think it's a good problem to deal with, and we hope to be able to bring some good advice and direction to the public as they have eagerly waited for these days to come.
Follow up?
So is that research being done in Ontario to try and tell if someone who has been vaccinated can spread COVID even after they've received the vaccination? And also, is this something where people that once you get a few people vaccinated, a few groups vaccinated, are they going to be able to get out and about in society, or are we going to have to wait until everyone has been vaccinated, or at least enough to gain herd immunity before people can start going out and about doing their daily chores and acting as if things are basically back to normal?
Well, you've pretty well covered the whole gambit of the discussions there. And those are all critical aspects. We are, and we will, now that we have vaccinated fully or immunized our long-term care residents, most of the staff in those and the retirement home residents as well. And we are still doing testing if we think there's any cases present in those areas there. So we will be testing some individuals who have been vaccinated to see if there is anything. So that ongoing parallel testing is happening now, early days still in that. As far as the overall aspect, I mean, we would like to have everyone vaccinated in the summer, if not sooner, in there. If people are vaccinated, then the risk of obtaining it from someone else becomes less concerning. If we eliminate grade down our cases of mortality and morbidity, and so our hospitalizations go down, it'd be a much different setting. And we would know we were building up more and more, use the term community immunity. As far as herd immunity, what you're asking there is that will we have a large amount that individuals who either can't receive the vaccine, and right now we haven't got a large number there, or what concerns me more, people who may be hesitant or not want to take the vaccine, can I assure them that they will not be exposed? That's the group I can't say right at the moment, because if people can still transmit while not being impacted by the disease themselves, they still might be able to transmit to individuals. And of course, if you're in a gathering or a group or whatever, do you know that everybody's been vaccinated in that group, or is there people not been vaccinated? And so these are questions and challenges we're going to have to face on a go forward to communicate to people when you are or not safe in there, and there's broader issues to be considered as well. So all very important parts that you've raised there.
Last question.
Colin DeMello at CTV News. Please go ahead.
Hi, good afternoon, Doctor. I just wanted to switch tracks here. The Minister of Long-Term Care says early on in the pandemic, she raised the issue of asymptomatic spread directly with you. I'm wondering, Dr. Williams, can you recount that conversation for us and what effect those concerns had on you at that time?
I don't know exactly which conversation that was. I think this is coming from I believe the transcript with the interview, which I haven't read. So I'm not sure of the content of that. I know that at different times, a number of individuals have asked that question and have postulated that. My position always on that is to ask my scientific advisors, both at the federal, provincial, territorial level, as well as with Public Health Ontario on our science table, of the evidence towards that and the support of that. So early on in those times there in the first wave and going into the summer, I had been advised at that time there was still not a lot of evidence to support asymptomatic transmission. We found a lot of individuals who said originally that they're asymptomatic. When you ask them more questions, they said, well, okay, I might have had this and that, but I didn't think it was a big deal. So we use the term posse-symptomatic, and so were people truly asymptomatic in that. And so there's aspects around the testing and its sensitivity, and a number of questions there that I keep asking our scientific table. So I have no problem with individuals, including various ministers, asking and postulating the question. But again, I would go back, and I'm very much connected with seeking the advice and direction, evidence from our scientific tables, and responding as they deem the evidence and expert opinions to be worthwhile, and when it should be taken a different direction or changed if that was the case.
Follow up, and this is the last question.
Do you feel, though, Doctor, that in hindsight, perhaps that was a mistake? I mean, you've been asked about whether or not why you didn't apply the precautionary principle here. Wouldn't it have made sense to, if there was any suspicion of asymptomatic spread, tracking the virus into long-term care homes, to just shut it down so as to prevent what eventually happened, which was about 3,800 deaths?
I think when you're asking these questions there, I think we applied the precautionary principle from my perspective throughout that time. We did not wait for case-controlled studies to show us the evidence. We've always asked when the evidence is lacking, to go to our scientific tables, to our experts, and seek a consensus of expert opinion, which is beyond the published peer-reviewed literature and evidence. So in that sense, we went beyond and used the precautionary principle to ask them to say, what would you recommend in this situation in the absence of definitive scientific studies at this time? So throughout this whole process, we have done that and exercised that. As far as the other aspect there, when we have outbreaks in our long-term care facilities, or individuals or staff that are identified, one positive case, we have been undertaking doing wider testing. As you may recall, when that assertion was put forward, early on we undertook a study with our health units to do a number of long-term care facilities and retirement homes that basically didn't have cases at the time, but they may have identified a case, and we tested everybody in there. And the assertion that there was asymptomatic transmission, therefore you had a lot of infection in those homes, was proven to be false. Our rate was less than 1%. In most of the case, they're very small. So the method always, if you haven't got COVID, you're probably not going to find it. So if there was asymptomatic transmission, and the assertion was that on two grounds: one, that your testing does not reveal the true case counts in the province or in your long-term care homes, then we would have gone in and found a whole bunch of cases in there, which we didn't find. The second point is that when people asserted that this had been going on and you had a 20% positivity in the province already by the middle of April and May, when they did the serial surveillance with Public Health Ontario, it came back at about 1.3% with a variation allowable up to 5 or 6% at the best. Again, ruling out that the assertion that widespread asymptomatic transmission was occurring, there was little evidence to support that, even up into May and June at that time.
Thanks, everyone.